Okay, thank you very much indeed. I think we now have some time for questions. Shane, I'm very grateful indeed for you outlining such a complex plan in such a short period of time. I think the plan will impact on everybody in this room, so I think there will be a lot of questions and a lot of issues to be addressed. Could those that are asking questions introduce themselves and perhaps indicate who they'd like to answer the question? We'll start with you, John, please.
Thank you. And thank you very much, Shane, for that. John Bridgewater, UCL. I think I heard you say it, but it'd be really good for a bit of clarification. The National Cancer Plan ambition for hospital to community, and then the necessary expertise to manage uncommon and rare cancers, not just cholangiocarcinoma, but pretty much a long list. Those appear to be diametrically opposite things. And it would be really good to hear you confirm that there needs to be a balance struck here between the division of labour and how to centralise without centralising.
How to centralise without centralising.
Correct.
That's a tricky one. But I think I 100% agree with what you're saying. That I think we had a lot of these discussions with the 10-year health plan team to say, overall, we would agree hospitals community is a good idea where people can be treated closer to home, and that will be the case for some immunotherapies. We should make that possible. But I think we've also been quite clear that actually one of the routes to reducing treatment variation will actually be more use of specialist centres and trying to reduce variation between hubs and spokes. So I think what we've said is that always has to be clinically led about what is most appropriate for patients. And in terms of the hospital to community shift, we do see that as being much more based around ongoing support for patients and providing more long-term support through the community.
Thanks. But we touched on this in fact, we spoke at some length about it in the patient session yesterday. Although the expertise is in the centres and you can't educate everyone to be an expert, you can't, obviously you can't do that. The care is in the community. The initial presentation of these patients is in the community. So we need everybody to be on board.
Yeah.
And so, there needs to be really quite a lot of sensitivity about the complexity of this arrangement.
Yes, I think I agree.
Yep, we're going to have a question from Helen next. I don't know if it's acceptable for the panel to ask a question, but you can. Please, Helen.
Sorry about that. Right, it's around the number of days that you stated people should have, if I've got this correct, people should have their diagnosis within 28 days, treatment pathway within 31 days, first treatment to begin within 62 days. But is that cumulative, or are you saying 62 days from diagnosis?
62 days from referral. So I think probably the critical ones for your first treatment are the 28 days to diagnosis and then 62 days from referral to treatment. And that 62 days only applies for the first treatment. So within 62 days of being referred by your GP, you should be getting a treatment. Now, the target for that is 85%. Where we are at the moment is about 70%. The figures for March should be coming out in about 25 minutes. So we've got quite a lot of work to do there. The 31-day target is 31 days from decision to treat to starting treatment, and that is for first treatments, but then also for any subsequent treatments that you might have. So if you're being referred, getting your diagnosis within 28 days, should be getting a decision to treat very quickly, and then that should take you on to being treated. You're getting your first treatment within 62 days. But I think it's also the 31 days is also there to make sure that any subsequent treatments you are getting, you should get those quickly as well.
Okay, it still sounds quite a long time when we're dealing with something like cholangiocarcinoma, where time really is of the essence. And I know it's very difficult, and I know targets have to be relatively reasonable. but I think sometimes when you're talking about the rare and less common cancers, I've had this conversation with others, and it's you can't have a two-tier thing where it's where it's a quicker pathway for one sort of a cancer than another. So, sorry, it's just
I think what's key is making sure that we have the right pathways in place, and trying to make sure that there are best time practice pathways to make sure that diagnosis is happening quickly, and hopefully then, once diagnosis has taken place, treatment will be prioritised.
okay. Thank you.
Okay, thank you very much. Joanne?
Hi, Juan Valle. I'm the Chief Medical Officer of the Cholangiocarcinoma Foundation based in the US, although until 3 years ago I was working here as a clinical academic. I'd like to follow on from Helen's comments, really. I welcome the fact that you're driving up cancer performance as one of the ambitions. My challenge would be, it's not ambitious enough. So if I was to put myself in a situation where I had a liver tumor and I needed to have a diagnosis, personally, as a patient, I would want my ultrasound, CT, MRI scan done within a few days, followed by a biopsy, start treatment in 2 weeks. That's what we would want, So I think setting this 62-day target is kind of artificial, and the reality is that all of those things are happening. You will get your ultrasound, you'll get your CT scan, you'll get your MRI scan, you'll get your biopsy, but we've built in these acceptable delays of another MDT, another scan appointment. And maybe what we need to be thinking about is much more ambitiously about how can we fast track and really limit those delays. The work is already happening. We're not adding more work. It's about how we can reconfigure that to make sure that things are happening. And I don't expect you to have an answer, but what I'm just doing is just reflecting.
Well, you
the
better
fact
allow him to choose an answer. Shane, please.
So I think a few things to unpack there. So first of all, those standards that we have not been met since 2015. So I think the first thing that we need to do is make sure that we meet those current standards. Now, we do have something in the plan to say that when we meet those standards by the end of this Parliament, we will look again at the performance standards and see if it is appropriate to make them more difficult to achieve, whether that is by changing timelines or by the percentage of people who should be meeting the current timelines. So I think that that's something that we do want to look at. We would recognise that in the future we would like to make them more ambitious. I think the second point about how do you reduce the unnecessary stages is a very good one. And I think that that is something that NHS England are trying to do, looking at the different pathways, trying to see, as I say, what is a best practice pathway to get you from referral to treatment as quickly as possible. One of the areas of work that we have with the Royal College of Radiologists is to look at the role of MDTs, because I think everyone agrees that MDTs are very important for cancer care, but they have grown and taken on more of a role than they need to be, and they can actually be something of a bottleneck. So we are working with the Royal College of Radiologists. I'm going to be with them this time next week to talk about how we can make sure that MDTs are, how they can, MDT meetings in particular can be reformed so that they are not, as you say, creating extra work, but are based around getting patients to diagnosis and to treatment as quickly as possible.
Okay.
Can I add to that very briefly as an international point of view a little bit? I practiced in the UK for 10 years and I am now back in Spain. My perception in the UK is that the whole diagnostic process was very, very slow. And when I was at the Christie, we had to repeat a baseline CT scan for every patient. My experience, because there was a long gap from the very first scan, so we had to repeat another one. So you are scanning the patient twice and using resources twice. Now I'm back in Spain, and without any effort, all my patients have the CT scan, first one with a suspected cancer, that I can use for chemotherapy baseline scan. And that is just, I think, a more dynamic process of the diagnosis, and I think that is the key. And maybe the numbers you have are appropriate for some types of cancer, but as Helen said, maybe you have to tailor them for specific scenarios. But it's not only my perception, I have spoken to other colleagues, and the diagnostic process in the UK is worryingly slow.
Okay, thanks. Shahid, can we go to the other microphone first, please? Apologies. So please, could you just say who you are and a short question, because we're going to run out of time.
Hi, I'm Andrea Sheardown. I've had cholangiocarcinoma, and I'm also a moderator in the support groups for other patients and carers. Obviously, a lot more of us are being diagnosed younger, and there's like a huge impact on our families, financially, mentally. You're sometimes the main breadwinner, and obviously you're trying to navigate the cancer, but also support your family. So is there areas that you're looking to improve on the financial side to support people going through the journey? And the other aspect of the question is, my children were very young and there wasn't the emotional support. Macmillan offered to give a group counselling session, but obviously you can't address the needs of the person battling the cancer being told they're not going to make it versus the children that obviously you can't talk about the same topics in the group setting, and there was nothing available for me that would have counselling for the children. They were classed as too young, so it's a huge area that, not just with this cancer, but lots of others, that's still an issue.
And sorry.
And she adds to that.
Yeah. So,
Sorry, can I just go back to Shahid? We're just going from one microphone to the
It's
other.
an add-on to Andrea's for about the Macmillan. So I'm Vanessa, 10-year survivor of cholangiocarcinoma. Macmillan's got a really postcode lottery. So in some areas we can get a Macmillan occupational therapist, a Macmillan physiotherapist. You move 5 miles away, you can't have that service. And it's just, and the digital systems don't talk to each other.
Okay, thank you. Shahid?
Shane, thank you for putting yourself in the spotlight at what's an interesting time for your department. I had a sort of comment and a question. One is, my name's Shahid Khan, and I'm a clinical academic at Imperial, and I'm also head of admissions for the medical school. And I just wanted to say that we need some more joined-up thinking, because the system is a biological system in society. And so, for example, under the last government, the number of medical schools increased, so the number of medical students increased, but the downstream training did not increase. So all that created was a bunch of new medical graduates who want to become radiologists and report these scans, who want to become GPs, but can't because there are no training pathways. So there needs to be some joined-up thinking. In this
Shahid, can I push you for a question? Because we've got 2 more minutes, and I know that there's a lot of other people that want to ask things from Shane.
So how do we ensure joined-up thinking to not just say, well, we'll get scans done quickly, but there's no radiologist to report them, so it takes 2 months to actually get your scan report. So one needs to think about that, and is that something that is on your radar about how to do that?
Shall I try and answer all the questions at once?
If you can, that would be great.
So on joined-up thinking, yes. So there is a workforce plan that will be coming out soon. We've been feeding into that, and I think you're absolutely right. There's no point in us investing in diagnostic equipment if we don't have anyone to read the scans, and I think it's something that we've been trying to make sure that we are joined up across, and I think that is very common in cancer, where you need to think a lot about the downstream impact. So we're talking there about 62 days. But I think, as we were hearing, and I think as you've been discussing, there is more and more molecular targeting for treatment. And so you need to think about, within that, how do you factor in genomic testing and make sure that you are getting that back in time for it to be able to influence treatment selection. So there's a lot of things that we need to join up. And I think workforce probably is one of the most crucial ones, thinking about, as both our plan and the 10-year health plan have set out, we are moving much more to trying to incorporate genomics, trying to think about digital. You need to think about, do you have the right skills within the workforce to make that happen?
Okay,
I'll come across to the other question.
Okay.
Yeah. So thank you very much for sharing that with me. So I think, first of all, one of the things that we've really tried to set out in the plan is that the ongoing support to patients should not just be medical, it should be holistic, and we should be thinking about financial support and wider emotional support, and that should be tailored to everyone's personal circumstances, including for, as you said, whether the patient has children and wants to get the emotional support and the psychosocial support to be able to talk to them about that. I think on Macmillan's postcode lottery, Macmillan are a fantastic partner, but I think we shouldn't be relying on them. We should be making sure that that is something that is available across the country. One of the things that we've set out in the plan is that we really want to make sure that those geographical inequalities are not occurring, and that we want to make sure that everyone is getting access to a high standard of care. I talked a lot about treatment when I was speaking, but we think that that should apply to post-treatment support as well. So I hope that has covered it.
Thanks, Shane. Can I ask you a more general question, Shane? You've mentioned about the rare cancers and the possibility of a director for rare cancer progress. I was actually phoned about this surprisingly last night. I'm the UK NIHR lead for surgery for the RDN. I must say I was not aware of this at all, that there was going to be a new NIHR-directed ZAR for rare cancers. And do you think NIHR is fit for purpose to drive improved cancer care?
So we work very closely with NIHR. I think they've obviously got a very strong focus on research, but what we want to make sure is that actually NIHR, I think to come back, sorry, I've lost you ask the last question, but the point about joined up thinking, actually there needs to be quite a lot of joined up thinking between the research side and the service delivery side, because I think particularly with rarer and less common cancers, it's not something where you say research happens over here, treatment happens over here. Often they need to be very closely linked. And just say we should be getting an ad out for that role very soon, so hopefully it will come to you as well. Sorry, I had a question.
Okay, perhaps the last question.
It's linked up to the joined up thinking. So I'm Beth, I'm a patient family member, but also an F2 doctor at one of the training bottlenecks. There's an issue with specialty training in primary care as well, because when patients are worried they can't get a GP appointment, they're more likely to put off symptoms that might actually be the step to earlier diagnosis. So my question was, is there any plans for increased funding to make these targets actually happen? Because we can set the targets, but how are we meeting them if we've not got the staff to meet them?
So I think in terms of primary care, that's something where we will be using some of the cancer programme budget to try and support primary care colleagues in identifying potential signs of cancer and when they should be referring onwards. So we've got quite a few programmes across different areas, different cancers, but also looking at what we can do with safety netting, what we can do with digital support for some of that. And I think in terms of funding, the government has put money in overall into the NHS, and some of that will be going towards workforce, and quite a lot of it has gone into diagnostics and treatments for cancer. On primary care, that's not something I'm as close to, so I can't say quite as much about that.
And also a lot of the typical safety netting symptoms aren't classical symptoms of rarer cancers like cholangiocarcinoma.
Yeah, so I think we've got the non-specific symptoms pathway to try and identify that. I think in terms of the other symptoms that are more difficult to do, we're looking into quite a few things. For example, with MSEDs to see if non-specific abdominal, if they can be used to pick up people with non-specific abdominal symptoms.
Okay, thank you very much. I think we need to move on. We're most grateful, Shane, indeed, for you coming along to discuss the cancer plan, and I hope that all the political changes improve the delivery of the cancer plan rather than inhibit it. And thank you very much once again.